most of speakers, they have reached here. If they have already deposited their presentation to the dais part. We are expecting 2 more judges to be there. In case they do not turn up in next 2 to 3 minutes, then we'll start session. Just hold on till that time. In the meantime, if all speakers are there, I'll just enumerate the important this thing for presentation. The duration of each video will be 8 minutes, as you might have been already conveyed, and the changing of presenting author is not allowed. There are marks for your presentation. These will be judged based on your the quality of presentation, originality, scientific content, and the cinematic content of your presentation. I am Professor R.L. Sharma, Professor Head Ophthalmology at IG Medical College, Shimla, and I am accompanied by a learned Dr. Sanjeev Mukherjee. He is from Banerjee, sorry. He is from West Bengal, Disha High Hospital. So if 2 more judges they join us, I am expecting then in next 2 minutes, since we have sufficient amount of time. This session will last till 17:30 p.m. Otherwise we'll start. In the meantime, if our first speaker is there, she can come forward and be there on the dais, so that there is no delay as far as the loading of presentation is concerned. Can you read out, Dr. Mukherjee, by putting this mic?
So the first presenter, the chief presenting author is Dr. Konika Bharadwaj. Please come up on the stage. Sorry? Oh, she is withdrawn. Okay, okay. So then, so the next presenting author, Dr. Ashok Vardhan. Dr. Ashok Vardhan.
So absent.
You can start?
You have named his
Yes, yes,
topic.
Dr.
Dr. Ashok Vardhan. Your topic of video is the sinkhole conquest. You can go ahead. Hello.
Posterior capsular rupture is one of the most dreaded complications during cataract surgery. The fear during IOL implantation is that it can cause further enlargement of the PC tear or even IOL drop. So the question arises, where to place the IOL? Literature shows that the rate of PCR varies between 0.2 and 14%. Posterior capsular dehiscence can be pre-existing in certain conditions such as PPC, following vitreoretinal procedures or trauma. Once posterior capsular tear is noticed, keep your calm and do not panic, as it can worsen the situation.
No. No! No! No!
Dr. Murphy!
No!
Make sure the anterior chamber is filled with viscoelastic before removing the instruments from the eye. Loosen the speculum of the eye. Assess the extent of the PCR and the amount of PC support available. proper anterior vitrectomy must be performed before attempting IOL placement. The ideal scenario following a PCR is to place a 3-piece IOL in the sulcus with reverse optic capture. If there's a small central PCR, it can be converted to a posterior continuous capsulorhexis and IOL placement in the bag can be achieved. However, a 3-piece backup IOL may not always be available, and PCC is not possible in linear PCRs. In such cases, can we still place a single-piece IOL in the bag? Your mission, should you choose to accept it, is to place the IOL in the bag. We highlight a few tips and mistakes to avoid to aid you in this mission. Posterior polar cataract have a greater propensity for PC dehiscence and a higher chance of PCR with vitreous disturbance intraoperatively. Advocate anterior vitrectomy is a necessity before planning IOL implantation. In these cases, wound-assisted IOL delivery must be avoided. IOL is carefully injected so that the leading haptic is guided into the bag, dialed into the area where PC support is available, and the trailing haptic gently flexed into the bag. Haptics of the IOL should be oriented parallel to the PCR. In cases where there is a pre-existing PCR, IV mannitol pre-operatively can be given in anticipation of an eventful surgery. Avoid hydrodissection in these cases, and careful hydrodelineation is to be done. All the phaco parameters are to be lowered. Peeling of the cortex is to be done from the periphery in all clock hours, and the posterior pole to be dealt last. A foldable IOL is to be placed in the bag after ensuring adequate PC support, and the haptics are to be oriented parallel to the PCR. In case of posterior polar cataract with PC plaque, PC polishing is to be strictly avoided as it may result in a PCR. Inadvertent removal of instruments must be avoided as it can cause AC collapse and further enlargement of the PCR, which is what happened in this case. After advocate vitrectomy, foldable IOL placed in the bag with haptics oriented parallel to the PCR. In this case, after initiation of rhexis, Argentinian flag sign was noted, which was converted into a round rhexis with the help of an Utrata forceps. A linear PCR was noted after last fragment removal. Inject viscoelastic to form the anterior chamber before withdrawal of the phaco probe. IOL is placed in the bag with the haptics oriented parallel to the PCR. In a retrospective analysis of 29 intraoperative PCR cases, we successfully managed to implant IOL in the bag in 22 cases. 1 year follow-up of these cases showed stable IOL and nil complications. Ensure anterior chamber does not collapse by injecting viscoelastic before removing the instruments. Assess the extent of PCR, and if adequate PC support is available for haptic placement, proper vitrectomy must be done. Viscoelastic should be washed off properly in front and behind the IOL. In case of a linear PCR, haptics should be oriented parallel to the PCR.
Mission accomplished!
So this is a comprehensive video showing the most common complications which we all encounter, the PC rupture. So what to expect when you encounter a problem. We should not be panicked, and we should maybe fill the chamber with visco and then remove the phaco probe, and loosen the speculum so that the intraocular pressure is less, and also do a proper vitrectomy. I think before you even encounter these patients, you should be prepared with a good vitrectomy, and also the IOL options. You should have a 3-piece acrylic lens as a backup if at all you're not able to place a single place lens in the bag. So the message is you can aim for an in-bag placement of the single piece IOL, because the single piece you should not place in the sulcus. It ideally should go into the bag. You can place it once you have a PC rupture that is just involving only 1/3 or less than 1/3 of the PC. So this is which we want to convey. This was done by Pondicherry Arvind team under Dr. Vivekanand. We'll be happy to take any questions if you want. So, and thank AIOC for giving us this opportunity to present. Thank you.
Thank you very much, Dr. Ashok. A beautiful video you have shown with all animations. And the important precaution you have already told, that it is just the release of speculum that will save many time you of the further vitreous loss or anything like that. And second part, you told that go for the dense viscoelastic as soon as you detect such thing. Apart from this, if you are doing phacoemulsification, what will be your further step, particularly if it happens during the cracking part or you have completed it? Yes, sir.
So what I follow is when I do the phaco chop, if at all I see a PC rupture during which already half of the nucleus has been emulsified, then I go ahead trying to do a slow phaco. If majority of the nucleus is still remaining behind when you do a phaco and you see a PC rupture already, so I switch to a superior manual small incision cataract surgery.
That was one of the most important message that should go to the audience here, that in case you land up in trouble, it's better not to go for the high pressure intraocular pressure surgery that happens in phacoemulsification, rather the lower pressure, that is if you convert to small incision cataract surgery, and that's a easier and lesser risky procedure once the complication has happened. Anything special, sir, if you want to give any precaution or any special to the post-operative care of these patients, that's very, very important.
So post-operatively, as you know, these patients, one is what we expect, they may have an intraocular pressure spike. So ideally, better you give topical anti-glaucoma medications or oral Diamox post-operatively. And also they may have an increased inflammation. If at all you place the lens in the sulcus, I mean, there may be some iris rubbing, and it's more of a complex surgery. So expect more inflammation. So you can maybe increase the steroids, and if needed, systemic steroids can be supplemented. And always follow these patients for with the retinal surgeon also. You may have a nuclear bit that is already in the vitreous, or you can have some retinal detachments also because you are doing vitrectomy. So always better a retina surgeon also sees these patients after a week or so that you ensure retina is also safe after you handle this complication.
Some word to the patient about the complication part. How do you manage that part?
I think it comes with experience. I think there's no other. So the more you do, the first is you manage complications of others. So we are more bolder when we manage complications of other surgeons. I think then we are more comfortable handling our own thing. And more, you need to have a good equipment. You need to have a good vitrectomy, and also a backup of a good intraocular lens, alternative methods. So those things should be there, and proper training. What are the rules of anterior vitrectomy? How much bottle height you should use? How much vacuum you can use? So I think those also really help in doing the procedure much better, doing the vitrectomy and also placing the lens. And also always constant mentoring by seniors, show your videos, get to know how it could have been managed, and those things I think really makes a surgeon better managing complications.
One word that I tell it to the patient and put it on the record is that this is a complicated cataract surgery. There is no harm, the complications are part of surgery. Always put that in record, let it be PCR, small PCR, large PCR, trivial PCR. Once you document it, then you tend to follow these patients, particularly if you do lots of cataract surgery. And sometimes it should be softly conveyed to the patient that intraocular lens has been implanted, but your surgery was difficult and it was more complicated than the others. That's how you handle the next post-operative corneal edema or reduced vision that these complain, and sometimes the retinal issue also that arises in this case.
Yeah, that's a good thing. Preparing the patient before the complex surgery and also the attenders of the patient is very important, as doctor says. Yeah,
Okay.
Thank you.
Okay, thank you very much,
Thank
sir.
you.
Thank you, Dr. Vardhan. The next video was double trouble, explanting the implanted removal of phakic IOL along with flax. Dr. Hemlata Gupta. Sir, please come to the stage with the mic.
Because mic will be there, sir, then it will be easy
So
for
your
you to
input
comment.
also, sir,
Ah.
please.
A very good evening to all of you. I'm Dr. Hemlata from Center for Sight Group of Eye Hospitals, New Delhi. I'll be showing a video
And a very warm
showing
welcome to
difficulties
all.
and tips
We
and
are a
tricks to
group
manage
of
those
cataract and
difficulties
refractive surgeons
in a
from
case,
New Delhi,
of combined
India,
eye
and
surgery
today
with,
I'll take you through the difficulties
eye
of
surgery
cataract
with
management.
Okay. Can you restart the video, please?
Yes,
We have no financial anyone, and a very warm welcome to all. We are a group of cataract and refractive surgeons from New Delhi, India, and today I'll take you through the difficulties of cataract management with the phakic IOL explantation and role of femtosecond laser in such cases. We have no financial interest to declare. Let us first understand the process of phakic IOL explantation. Why is it required? When is it done? And how it is done? The anterior subcapsular cataract seen in the picture is the most common morphological type of presentation and can be easily dealt with surgically. Most surgeons fear using femtosecond laser in such cases of combined cataract with phakic IOL explantation. However, I will show some tricks how we can benefit using a flax in such cases. Once the laser prompts for modifications after its scanning, we need to guide the system to avoid confusion of phakic IOL with natural lens surface. Both the anterior and posterior surfaces are modified, and also posterior capsule is adjusted for a safety cushion. The pupillary opening is centered and iris circle is guided. Once the laser platform accepts the modifications, we then proceed to laser delivery. Not only do we get a very precise anterior capsulotomy, but also we can choose how to divide the nucleus. The anterior capsulotomy, the nucleus division, the limbal relaxing incisions are all managed within the matter of a few seconds using the femtosecond laser. Now let us delve into the surgical video. Notice the precise and round capsular axis and neat nuclear division. The main incision is enlarged in order to explant the phakic IOL more comfortably. Liberal use of dispersive OVDs is preferred, and all the haptics are untucked one by one. A microforceps or a smile forceps can be used to grasp one of the edge of the phakic IOL, while the other instrument can be used to gently guide it and explant out of the main incision. We then proceed with the usual steps of a cataract surgery. Notice how the capsulotomy is freely floating and there was no interference of the phakic IOL during the capsulotomy using femtolaser. The end result is a beautifully performed combined procedure. Let us now understand what is not to be done in such cases. Notice the vigorous movements by the surgeon in order to grasp the edge of the phakic IOL. The rough explantation leads to pupillary sphincter tear, iris bleed,
and even main wound architecture destruction. Let's learn about the handshake technique for phakic IOL explantation. In the present case of post-ICL uveitic cataract, the ICL haptics are untucked using two instruments and copious viscoelastics. We first deliver one haptic in the wound and then patiently and gently guide the entire ICL out with two instruments holding alternately. This is what we call the handshake technique of phakic IOL explantation. Here is another surgical video of a patient with cataract after phakic IOL implantation, which was then treated using the femto laser assisted cataract surgery. After docking and first scan, the femto laser prompts a modification required dialog box. Click OK and then proceed to the modifications. Notice the green line falling on the anterior surface of phakic IOL, which is wrongly identified as the anterior lens capsule by the laser platform. We then manually guide and place the green line corresponding to the anterior lens capsule by shifting it below the phakic IOL level. Similarly, we guide the posterior capsular mark slightly superior intentionally in order to fashion a safety cushion for the posterior capsule. The femto laser also helps with the toric markings for the toric IOL placement. The digital marking systems also help in cases where we have to implant a toric IOL and they do not interfere with the present phakic IOL inside the cataractous eye. After untucking all the haptics one by one, the phakic IOL is horizontally oriented and the edge is lifted using viscoelastic devices in order to grasp better. We then proceed with the usual steps of cataract surgery and then follow with the implantation of a toric IOL using the digital marking guiding systems. So, with our examples, we try to prove here that femto laser is actually a very good assistive technology when it comes to operating cataracts after ICL or phakic IOL implantation. And we can efficiently combine the explantation of a phakic IOL and replace it with another intraocular lens using the femto laser assisted cataract surgery. So now, to conclude, let us brush through the teachings that we learned today using these case examples. Firstly, femto laser is a great technique in post-phakic IOL cases. It also helps us with toric markings. The key is to be patient. We should untuck all four haptics one by one and explant using the handshake technique. We should also protect the endothelium with liberal use of dispersive OVDs. And lastly, we should be gentle in order not to disturb the main wound architecture. So the take-home message for today is that phakic IOL does not interfere with femto laser, and with proper planning, excellent results are guaranteed using a flax for IOL explantation and cataract surgery. Namaste and thank you for your patient listening.
Can I ask?
Yes, sir.
Okay, so you said you enlarged the wound a little bit. So what's your wound size? Does it compromise your phaco-dynamics?
Not really, sir. It's like 2.2. We enlarge it to 2.8.
And
So
yeah,
the
yeah,
phaco
correct.
probe we use is 2.8.
Which phakic IOLs were this? Indian or Star?
This was few cases are for star ICL, which was the previous version without
Yes,
centroflow.
yeah.
So there were like more cataract, chances of cataract with those kind of ICLs. With centroflow, it's like minimal.
Yeah. Very nice. Thank you.
And one question I want to ask you. So you got a lot of cases. So how many, I think, did you get free flap in all your cases?
Free flap in all cases.
In cause, that's
we
good.
work on a catalyst platform and
Yeah,
that's really
because you need to adjust manually. That's why very crucial at this thing.
So it's almost free floating
Yes,
in all
that's
the cases.
nice. Good, thank you.
How much was the drop in visual acuity following these complicated ICLs?
There's no drop, sir. Whatever drop is because of the cataract.
Okay, yes,
that
that's
is there.
it has gone down to the complication or on average how much time
Because
after
of
implantation?
cataract, whatever glare and drop in vision is there, because of that the patient
The indication to operate
removed
was
the-
actually
yes, is the cataract.
visual, or it was something complicated? Visual only.
Visual. In one
Nothing
of the
like
cases,
glaucoma, inflammation,
in
or
one of the cases it was uveitis post ICL, so we had complicated cataract as well as a recurrent uveitis, so we had to remove the ICL. In most of the other cases it was just cataract.
I could see some pigmentation there behind the.
So that was one case.
Okay, so it was part of those complicated indication where you feel that it should be explanted, and most of them were replaced with the intraocular lens.
If the uveitis is because of the ICL, then we have to take out the ICL, otherwise it doesn't respond.
Okay.
Just
2-3 cases we have done.
one more thought. What was your height when you do your anterior capsulotomy for the laser?
So the main thing is that sometimes the laser identifies the ICL
No,
as
no.
medial surface.
The height for the capsulotomy. You know, the capsulotomy does a punch, but you can adjust the height
We
for
can
the
adjust
laser.
the energy parameters also.
Not
We
the
can increase
not the
energy
energy. I'm talking of the height.
height of the capsular.
Yeah, because what I just thought now for a process that in our, I have a Z8. I had a catalyst before, so we can adjust the height. So you can make it, you know, X 400 microns, 500 microns above the anterior capsule or below the anterior capsule. You can adjust it. I was just thinking, if you make it big, can it cut your ICL additionally? I was just thinking now, as a thought process, you can.
Catheter is around. In
Yeah,
any
so you
case,
can
we'll
get
have
it out
to
and then there's a stick it. I'm just talking
expand, yeah.
for the sake of talking, but
We can try.
yeah. And there's no harm in, I mean,
There's
there's
no
nothing
harm
wrong in this. I wanted to know because the height, if it is more, I can adjust the height to 1 millimeter. So in hypermature cataracts, normally they say when it decompresses, the capsule comes up, so your setting in your anterior capsulotomy should be high. That's what.
Maybe we get a crack and it's
Correct,
easier to
correct,
expand. Yeah.
Thank you.
Thank you so much.
Okay, thank you.
So next video is precision in chaos, DMEC in complex bullous keratopathy. Dr. Pooja Patil.
Good afternoon all. I'm Dr. Pooja Patil and my presentation is on precision in chaos, DMEC and complex bullous keratopathies.
The author does not have any financial interest in this video. Bullous keratopathy is a commonly encountered pathology in the OPD. Less frequently, the patient presents in early stage with no stromal scarring, good view of antechamber, and normal functioning pupil. Rather, more commonly, they present either with stromal scarring obscuring the view of antechamber, eccentric pupil, atrophic iris, fixed dilated pupil, subluxated IOL, or either combination of above. So, this is a case of 65-year-old male diagnosed with left eye pseudophakic bullous keratopathy having a visual acuity of counting finger at 2 meters. The patient had a poor view of antechamber, associated peripheral antesynechiae from 3 o'clock to 9 o'clock hour, and fixed mid-dilated pupil. The patient was planned for Descemet membrane endothelial keratoplasty. Epithelial stripping is performed using scraper to improve the view of antechamber. Centration is marked and 7 mm marking is done using caliper. Corneal incision using 2.8 mm keratome is made. Viscoelastic is injected to inflate the antechamber. Iris repositor is used to break the anterior synechiae. Maneuvering of the instrument to break the synechiae is done in such a way so that there is minimal stretch at the root of the iris so as to prevent iridodialysis and bleeding from the angles. Gentle stripping of the iris repositor is done at the angles to break the peripheral anterior synechiae. a transparent membranous structure with pigment deposits is noted, which is attached to the iris and is identified as detached descemet membrane. Stripping of the detached descemet membrane is done. Remnants of the descemet membrane are removed using Utrata forceps. Still, there is some descemet membrane attached to the iris which is cleaved using the Vanna scissor. The remnant descemet membrane is removed using the forceps. Visco wash is performed. .2% pilocarpine is injected to bring down the pupil size. One can notice that there is some descemet membrane still attached at the pupillary margin. An attempt is made to strip the remnant descemet membrane attached at the pupillary margin. However, it fails to separate. 20 gauge cutter is used to nibble the edges of descemet membrane which is attached at the pupillary margin. It is important because it may hinder the DMEC graft unfolding. Care is taken not to damage the sphincter. Peripheral iridotomy is made at 6 o'clock using the cutter. Visco wash is performed. A standard protocol is followed to make a 7 mm DMEC graft. Graft is then loaded using the injector prepared from the IL cartridge. Gentle taps are made using 27 gauge cannula to unfold the graft in correct orientation and center it. Intermittently, the anterior chamber is shallowed to prevent the re-scrolling of the graft. After ensuring the correct orientation and centration, air is injected in the anterior chamber to fix the graft. Antibiotic drops are instilled and BCL is applied. On post-op day 1, the graft appeared to be well attached as confirmed on ASOCT. At 1 week post-op, the cornea appeared clear and compact and vision improved to 20/60. Since every case of pseudophakic bullous keratopathy is unique in its own way, a careful pre-op planning is needed. In chronic cases of bullous keratopathy, the maneuvering inside the anterior chamber should be as gentle as possible to avoid anterior chamber bleeding, which can make the surgery more challenging. Also, it is imperative to counsel the patient regarding the expectations and the outcomes of surgery for better compliance with the postoperative care.
Very nice presentation. I have two questions. You struggled with the utrata because the utrata was a straight tip down. So there's no reverse utrata. Is there a reverse utrata manufactured or available? Like a reverse Sinsky? So do you have anything like that? You can design an instrument called a reverse utrata. Normally utrata goes like this and pointed down. If you had a reverse utrata, then you can easily hold it. So that's one. Then you did not have any sign like what I've seen. I'm not much experienced in DMEC or DZEC or all these surgeries, but you did not have any sign on the scroll which will ensure.
F was there.
F was there. Okay, I missed that part.
There was F
Okay,
was
okay. I just wanted to know.
Okay.
Very nice presentation.
Very nice. One thing I just want to add, this your marking, that is, it is very, the wide. So it's obscuring your field, your marking. It is obscuring in some of the areas. And second thing, once there is pass, the IDs has got very good memory. So it will again attach, as you come forward and again create the pass. So what is your post-op? How is your post-op in this patient? So AC was formed. So after 2 to 3 months, the pass will form. So what was the graft size? It was 7. It's okay. Okay, thank you.
Did this patient have glaucoma also? As you show us that there were multiple anterior synechia and whole of angle seemed to be closed.
It had peripheral synechy. The patient had peripheral synechy from 3 to 9 o'clock, but yet the IOP wasn't raised and the patient didn't have any signs of glaucoma per se on the disc or yet it had not developed.
Okay. How much post-operative this patient was that you did the keratoplasty? That is, how old was this previous surgery? It was for some kind of complicated.
Yes, sir,
Okay, it's
after 3
not
months.
very long.
Yeah.
So that's an important parameter.
Yes,
If it
sir.
is a long-standing.
As early as possible, if we take it, then the
more-
visual outcome will be better.
Yes, the endothelial keratoplasty is one of the most challenging cataract surgery, most challenging surgery that the eye surgeon performs.
Yes, sir.
More important than that is the anterior segment repair and reconstruction that you were thoroughly doing it. If you manage that part well, there are multiple issues including these synechia, pigment dispersion, IOL related issue, displaced IOL, and scarring all around that you encountered the way. So the keratoplasty results are excellent post-operatively as
Yes,
you
sir.
show, provided you have focused on all the issue related to the
All the
other
root causes
anterior
are
segment
treated first and
reconstruction. Thank you very much and excellent presentation.
Thank you, sir.
Next video is flipping the flap, salvaging a free cap with central
This is a case of salvaging a free cap with central stripe post LASIK. A 22-year-old.
So many a times we read a lot on basic science, but we are not able to translate it into clinical practice. And in this case, particularly, it was a very challenging situation. And the video is self-illustrating on how the laboratory science was actually translated into clinical practice.
This is a
and
case
intraoperative
of
science.
salvaging a free cap with central stripe post LASIK. A 22-year-old male presented 7 days post LASIK with central stripe. Visual acuity was not improving beyond 6/18. Surgeon was unavailable to comment. Flap striae were noted. It is important to understand that diagnosis of striae can be done by instilling fluorescein and noting uneven pooling of tear film after a blink, or by dilating the patient and noting under retroillumination. Based on these, the initial surgical plan was made. Steps of flap ironing include careful removal of epithelium, dissection of flap along the edges, reflection of flap over hinge, floating and stretching back with blunt forceps, flap pushed gently and firmly away from the central cornea. This is a filed case in which nasal hinge had been done. flap is gently stretched. To prevent dead space, based on this, we started our case and unfortunately met with a surprise. Flap dissection was started from nasal to remove the epithelium. To our surprise, the edge got lifted and the entire cap came off in a circular manner. We assumed that a hinged flap was present, realized that it was a free cap, and now we were uncertain if the flap had been positioned upside down. We course corrected. And started by removing the epithelium gently with a hockey stick. Difficulty being the flap was moving because there was no hinge. To identify which side was up, whether the epithelial basement membrane was upside down or the stroma was upside down, we stained it with trypan blue and looked for visual and tactile clues. For the purpose of this presentation, we did a small experiment to identify the flip and the flop side. For this, we used a dissect cap and removed the epithelium completely. Trypan blue staining was used and found that stromal side absorbs stain more diffusely, whereas the epithelial side shows a different smooth structure. The scientific basis is that the Bowman's layer histologically is smooth, whereas stromal fibers are irregular. This gives us visual differentiation for assessing the orientation and is useful in ambiguous or trauma cases. We took a dissect cap, carefully removed the epithelium. The stromal surface was marked at the edge and the epithelial surface was marked in the center. Trypan blue dye, freely available in the OT, was used to stain both the surfaces for 20 seconds. Excess dye was removed with Merocell sponge. Epithelial side can be clearly seen to be more shiny and smooth, whereas the stromal side is more irregular and taking up more dye. Having established the correct orientation of the flap, we now proceeded to ironing the flap and repositioning it in the central circular gutter that had been created because of it being a free circular flap. With gentle movement and compression, the flap was reposited perfectly into the defect. Excess saline was drained off using a Merocell sponge. To prevent the dislocation of the flap, now as well as post-operatively, we used overlay suturing with 10-0 monofilament nylon. No attempt was made to bury the knot as this would result in more microstriae. A bandage contact lens was applied. Post-operatively, the patient was followed up for a period of 8 weeks. At 3 weeks, the bandage contact lens was removed. No striae were noted overlying the pupillary area. However, some amount of haze persisted even at 6 weeks post-operatively. Patient's visual acuity, however, improved to 6/9 and staining showed no striae in the central area. We want to highlight that free caps may masquerade
as hinged flaps. A careful orientation of the flap is critical in such cases as epithelium may have grown over either surface. Trypan blue is a valuable adjunct in identifying the orientation. Timing of intervention is crucial since flap striae respond well to stretching within 2 weeks.
Nice, very innovative. But I have 2-3 important questions. One is, where is your pre-op OCT, flap thickness, and epithelial thickness in the area of the striae? So that's one thing in today's era, we know that the epithelium thickens, and that's why you remove the epithelium when you have to remove the striae. And one more interesting thing, what I thought was, whenever I have a re-lift, I normally mark. So you don't mark in a re-lift routinely?
We do, sir. We do.
So you didn't mark in this case?
In this case, certainly.
Yeah, so if you mark, you don't need to do all this, but it's a nice innovation, nevertheless, because I think that made you think, and that's how you innovated this. But in today's era, I feel my question would be, what was the original flap thickness, which microkeratome? Of course, you don't know the details, but nowadays with OCT, we can easily make out what was the flap thickness, and you know where it is. And normally we mark, we know where to go, because it's sometimes very difficult to get an edge. You know that under, you know the, I mean, you operated this under which microscope?
Lumera.
So that's good. Normally we operate this under the excimer microscope, and they are the worst microscopes on earth because they're not coaxial. So it's nice, another take-home message to do that in a cataract OT and don't do it in the LASIK OT. Normally we do this in a LASIK OT, but nevertheless it's a good innovation.
So epithelial, retrospectively thinking, epithelial thickness would have been very, very useful. But
Yeah.
on cursory examination, it looked like a very straightforward case. The surgeon also said.
No, everything is correct, but this would have made it complete.
True, I agree.
That's the only thing. I mean, we know what happens. We know that the epithelium holds the striae, so you have to remove it, etc. Because then the thought is, I have removed epithelium from a 90 micron flap. If your epithelium is 55, then your flap becomes really, really thin. So that's another care you have to take during a surgical step. But this is nice thought process. Thank you.
Thank you.
Nice video. Thank you. Anything to ask?
Just the dye which stay in that area, how it behaved post-operatively, how much time it took to disappear this dye.
So I saw the patient first post-op day, 1 week post-op and 1 month post-op. First post-op, it was still looking bluish, but 1 week it had gone, sir.
Because it is also toxic to the tissue also. That's why it might stay there for some time and might hamper.
So we routinely use it for DSEC and DMEX, and it definitely goes away. So if the endothelium can tolerate it, the epithelium and stroma can. Another area also, even sometimes for DALK caps, to ensure that the endothelium is completely removed, we also use it very routinely. So the interface generally it tends to go, sir.
Okay, thank you.
Thank you.
One more thought was, this suture was kept how long?
I removed it at 3 weeks post.
So have you done this without suture? Have you, I mean, I've done it, I'm not good with sutures, so I've done this without sutures and flaps do very, very well. They stick very well.
But that crucial piece of information as what was the thickness of the flap was missing.
Next video, my first gonioscopy assisted transluminal trabeculectomy in a infantile PCG, a surgical insight. Dr. Vesh A.S. think he is not here. Okay. Next. Announce.
If this was to be presented by Dr. Vishak, he is not there.
No.
So our next presenter is Dr. Vivekanandan, VR. He will be speaking on Thorax My Way. Yes, please.
Toric marking. Toric marking with reference marker blade is usually done by surgeon himself, which is time consuming, or by another surgeon outside the OR, which may not be reliable. There are also expensive systems such as Virion and Aura for the same. We therefore present to you a precise and simple technique. When the patient agrees for a toric intraocular lens, a few extra minutes on the slit lamp is all we need. Care is taken to avoid head tilt. With a coaxial slit lamp examination, a thin vertical slit at 90-degree axis is aligned with the Purkinje image on the cornea, which splits the cornea into two equal halves. Anatomical landmarks such as cleared blood vessels and pigmentations corresponding to 90 and 270 degrees are identified and replicated on the case sheet. A horizontal slit at 0 degrees is then made, and similar anatomical landmarks are identified and sketched on the case sheet. A few examples are shown here. In the OR, an assistant holds the sketch according to the orientation of the patient's eye and the surgeon's position. The sketch is then carefully compared with the patient's eye on table. The anatomical landmarks are identified and the corresponding points are marked at 0, 180, 270 and 90 degrees respectively. The toric ring is then placed on the eye and aligned with the markings already made. Incision location and axis of placement are marked. Care is taken to make a central 5 mm round capsulorhexis. We then proceed with the phacoemulsification procedure. We prefer to use sodium hyaluronate to inflate the bag and fill the anterior chamber. Toric intraocular lens is injected into the bag. During visco wash, care should be taken for its complete removal from beneath the lens as well. The lens is then dialed to the desired axis. Now, are we accurate? Yes, we are. We compared these reference marking with Varion image guided system and got a perfect match.
A very nice presentation, but I have one simple question where the biggest flaw happens. You are looking at the limbal vessels, which is correct, but you make the slit horizontal, where is the patient looking? And the next question is, what is the size of your pupil when you're making your slit horizontal? Because if your slit, which is horizontal, is slightly up or slightly down, you're going to have an error. So you are covering up the error by looking at the limbal vessels. But the limbal vessels has to be noticed at the level of the limbus, not beyond, because it has no relevance there. So my question would be, if you are doing this horizontally on a slit lamp, my thought process is that the patient has to look at the light, point 1, pupil has to constrict, point 2, your horizontal light has to be having half the pupil above and half the pupil below. Then only this is error proof.
Yes.
If the pupil is not exactly centered, this is not error proof.
Exactly, sir, exactly.
So that also you should highlight in this video, because if you make an error there, it's gone.
It's gone. Correct, sir.
That's my thought.
Yes, yes. So
And also one more thing, other than making a drawing, you could have taken the original photograph. That would have been more precise.
yeah, I was about to say that, sir.
Yes.
Now we do that.
Taking
Take
the
a picture,
photograph, yeah.
So on the
That will
tablet
be
we
more-
mark the things, and on
yeah,
OT
yeah.
the tablet is shown. I didn't add that part. But
so
this is what we do now. We don't draw this. We don't have case sheets anymore, so that's become
Saves your
obsolete.
time also.
Yeah, yeah. Saves.
you took your light as coaxial just to ensure that patient is looking in the center and a pupil is there in the
Yes, sir.
center.
I aligned the slit along with the Purkinje image so that it bisects the cornea into half.
That was your rough
Yes,
reference.
that is the thing.
Otherwise, these natural marking, they are quite sure to be there, those
Yes, sir.
vessels.
Yes, yes, sir.
They do
Yes.
not move around.
I was in a
Once you are
peripheral
putting-
center for 3 years, sir, where I was the only surgeon. So for torics, I had to come out, and it was taking a lot of time. So I didn't want to do that. I started doing this, and I had 100% accurate in that 3 years. I must have maybe probably 20 cases every year, 20, 30 cases at that time. It was a very long time ago. So it was accurate. So I wanted to document that. I wanted to share that thought.
So yes, you are absolutely right. I mean, there is no doubt that it is very accurate, but in the peripheral center, this is the best you can do. There is no
Yes,
doubt about it.
yes.
And you have verified it again with the Virion.
Yes.
So that's additional information. Only thing here is that if you want to place the lens at 16 degrees, 18 degrees, you still need a toric marker.
Yeah, we need a marker.
Yeah,
We
you
need a
still need
marker,
that. You
yes.
can't overcome that part.
Yeah,
So
yes.
here you're getting only a 80, 180, 90, perfect accurate marking.
Yes.
But the rest of it is still
You
done
need
with
that
the,
device
yeah,
for
yeah,
every
yeah,
case
yeah,
just to verify the axis.
Very nice.
Yes. Thank you.
So next is Dr. Akanksha Sharma.
Good evening, everyone. So I'll be discussing a challenging case of cataract surgery in a nano-ophthalmic eye, in which we did prophylactic scleral window.
Small eyes, big problem. Cataract surgery with prophylactic scleral window in a nano-ophthalmic eye. I don't have any financial disclosures to make. A 57-year-old female presented to us with bilateral nano-ophthalmos and angle closure glaucoma. She was planned for left eye cataract surgery. She had an axial length of 16.9 mm and anterior chamber depth of 2.03 mm. We did prophylactic scleral window assisted cataract surgery in this patient. There are various challenges in a cataract surgery of nano-ophthalmic eye. The most dreaded and the most common complication is uveal effusion in the patients of nano-ophthalmos after cataract surgery. There have been multiple case reports and studies describing the role of partial thickness sclerectomy in patient of nano-ophthalmos related uveal effusion. So in this case, we have done prophylactic sclerectomy along with cataract surgery in a nano-ophthalmic eye. A partial thickness corneal traction suture was placed with 6-0 vicryl followed by localized conjunctival peritomy in the infratemporal quadrant. Gentle cautery was performed. Of partial thickness rectangular scleral flap was made about 6 mm away from the limbus. This was made using 15-degree blade and a crescent knife. After the formation of scleral flap, a partial thickness sclerostomy was made till the uveal show was seen, as can be seen in this picture. Once the uveal show was adequate, the partial thickness scleral flap was sutured with 10-0 nylon. Subsequently, the conjunctival peritomy was sutured with 8-0 Vicryl and the cataract surgery was started. There was suboptimal pupil dilatation along with hard cataract. Iris hooks assisted cataract surgery was done. 4 iris hooks were placed into the anterior chamber after the formation of 4 paracentesis, and injection of viscoelastic was done to form the AC. Once the pupillary dilatation was adequately achieved with the iris hooks, anterior capsule was stained with trypan blue dye. Capsulorhexis was performed with the help of microrhexis forceps. Phacoemulsification was done using direct chop technique and the nuclear matter was completely removed. Subsequently, cortex removal was done using irrigation and aspiration cannula. The capsular bag was then filled with cohesive viscoelastic and single-piece hydrophobic lens of +39 diopter was implanted within the capsular bag. Iris hooks were removed and the viscoelastic was aspirated from the anterior chamber. At last, the ports were hydrated and the anterior chamber was maintained. On post-op day 1, patient had a good visual acuity of 6/60 and an IOP of 12 mm of mercury, and the IOL was well centered and the AC was deep. On the last follow-up at post-op day 6p, patient had an intraocular pressure of 14 mm of mercury on 2 anti-glaucoma medications.
I missed the part. What was the diopter of this IOL?
39 diopter.
So it's really not that much nanophthalmic.
Axial length was 16.
So what I miss here is you finish your video in 4 minutes. You could have given more details of actual length, lens calculation, IOL, which company, because 39 is, which company IOL did you use?
So this was SN, the single piece 39 diopter.
Because I have done only one nanophthalmic eye, a few others, but I have put a 65 diopter IOL made by AIOC, and we had full data, etc. But my thought process would be that in your future videos, when you present an interesting case, your main stress here was to make the sclerostomy, but in a 39 diopter, you could have still escaped without a sclerostomy and not had any problems, given mannitol, Dimox, atropine.
Actually, the other eye had choroidal effusions.
That's why. Okay, understood. So that also is not there in the video. So if that was there, then that would have made it more relevant. But very nice presentation.
What was the postoperative outcome of the visual acuity in this case?
So this patient achieved visual acuity of 618, best corrected visual acuity, because she had total cup disc pallors. That's why she couldn't, attain.
Age of the patient, I do not what was the age of the patient?
It was 60, I think 58, 60, I'm 50, yeah.
Okay.
Yeah, female.
You said 58,
okay.
Bilateral.
Okay, thank you. Nice management.
Thank you. Next presenter, Dr. Shivam Gupta.
Hello, very good morning, good evening to all. So I'll be presenting my video on bleb needling and how it can rescue a failing bleb.
Bleb failure can happen due to sclerosis at bleb capsule, at scleral flap, or at sclerostomy site. First, let's discuss prerequisites of surgery. Gnoscopy should be done to look for internal osteopatency. There must be some residual elevation of the bleb. Conjunctival mobility can be checked with sterile moist cotton swab. Patient should not be on any anticoagulants. Bleb needling should be augmented with antimetabolites. If you are using mitomycin C, it should be 0.1 milliliters or 0.4 milligrams per ml MMC with 0.1 milliliters sterile 1% lidocaine, the final concentration being 0.2 milligrams per ml. It is injected before needling 6 to 8 millimeters away from the limbus. 5 to 10 minutes prior to the procedure. Bleb needling can be done using needle or a MVR blade. Now let's see steps of bleb needling. To start, injection MMC is injected 6 to 8 millimeters behind the limbus. A spatula is used to prevent further migration anteriorly. The needle with bevel up is introduced subconjunctively 4 to 5 millimeters away from the bleb site. Needle is carefully moved side to side, breaking episcopal adhesions until the bleb is reformed. A small paracentesis entry is made. An anterior chamber and bleb are reformed. Now let's see a case of bleb needling in faking patient. Using 30 gauge needle, a mitomycin C mixture is injected superior temporarily 5 to 6 millimeters away from the bleb as the patient looks down. Patient is then asked to close the eye and the eye is massaged approximately 2 to 5 minutes. Corneal anchoring suture is taken. Paracentesis entry is made and AC maintainer is introduced. Here we are using a TB syringe with a bent 27 gauge needle. Remember, bevel of the needle is the part cutting the adhesion. So throughout the procedure, we have to follow the globe contour. Finally, AC is formed with BSS by hydrating paracentesis resulting in bleb elevation. Bleb needling can be performed AB interno by using Grover's spatula. Corneal traction suture is taken. Injection MMC is injected 6 to 8 millimeters behind the limbus. Spatula is used to prevent excessive anterior migration of mitomycin C. Paracentesis is created. Timber is formed using OVD. Spatula is then introduced through the paracentesis site, which gently slides through the ostium below this covered flap, ultimately making its way to the subconjunctural space. Similar procedure is repeated from the other side. A safer way of doing this is under direct visualization of goniolens. The Grover's spatula is introduced through the ostium with direct visualization. Bleb needling can be done as an outpatient procedure on slit lamp. It is cost-effective, less time-consuming, with added psychological advantage of patient not revisiting operation theatre. Steps are almost similar as discussed previously. Slit lamp examination, tonometry, as well as Seidel testing should be usually performed 30 minutes after the procedure. Post-operatively, topical steroids and antibiotics are usually prescribed for 4 to 6 weeks along with psychiatric care. Rarely, bleb needling can land up in complications like hyphema, blebitis, hypertony, leading to choroidal detachment and even end-off. Some of the known risk factors for failed needling are pre-procedure intraocular pressure more than 30, trabelectomy performed without use of mitomycin C, immediate post-procedure intraocular pressure more than 10, bleb needling done after 4 months of trabelectomy. To conclude, bleb needling can rescue a failing bleb, save patients' burden of using multiple AGM and repeat surgery. Needling may convert a failed bleb into a more diffuse bleb, which reduce the risk of bleb leakage and late endophthalmitis. Bleb needling should be considered when bleb fails post-surgery.
Thank you.
Nice.
Thank you, sir.
So, what's your upper limit of how many times would you do needling? And then you say, no, this is now over and I have to redo a surgery.
So, with the help of mitomycin C, if we are using, so we have a larger period of window of doing it. We can extend up to 3 months to almost 4 months. We can go ahead if we are used MMC before during the trabeculectomy, during the initial surgery. But once the fibrosis sets in, and there are papers which are even saying up till 1 year, but of course the failure rates will increase.
Most of these flaps were avascular almost. Whether if it is a highly vascular failed bleb, will you attempt similar procedure?
A highly vascular bleb may be a tenon cyst which is forming. So I'll first increase the dose of steroid and look for the particular tenon cystic area. I'll do all the ALS and look at the goniopatency also once. Then I'll go ahead with it, sir.
Okay. Otherwise, it's a bit risky because it bleeds profusely and there will be constant anterior.
Definitely, sir. And the bleeding will again cause the failure of the bleb.
Okay. So that's the situation where we usually do not attempt needling, rather go for the retrap.
Definitely, sir.
Okay. Thank you.
Thank you, sir. Thank you.
Thank you. The next is Dr. Chittam Senthil Nathan. Old is gold. I think he is not here.
If he is supposed to be the last speaker of this session, if he is not there, then we can conclude this session. I thank you all my co-panelists, Dr. Kumar, Dr. Rajiv, Dr. Mukherjee, Banerjee for the accompanying of this session. And I'll, if the photographer is there, we can have a group photograph with the speakers. But I think good number of speakers have left. Those of who you are there, you can come on the stage for group photographs. हाँ, इसको बाद में